topic is current concepts in management of traumatic macular holes, to peel or to wait. So just a small introduction about traumatic macular hole. It's commonly seen in young males. The etiology is a closed globe trauma, 1.4%, or open globe injuries, 0.15%. Then laser injury, surgical trauma, lightning strikes, electric shocks are some of the common causes. The prognosis is rather uncertain due to accompanying trauma-induced retinal pathology such as commotio-retinae, vitreous hemorrhage, retinal hemorrhage, choroidal rupture, RPE damage, subretinal neovascularization, and fibrosis. So the pathogenesis, there's AP vitreous traction on the fovea causing true loss of foveal tissue, and the equatorial expansion of the globe following the blunt trauma, which results in tangential vitreoretinal forces transmitted to the macula, with centripetal forces separating the neurosensory layers at the fovea. This results in a full thickness hole with a central defect without any loss of foveal tissue. So some clinical pearls. When examining the patient, we should always remember to check for RAPD and angle recession prior to dilatation, because the trauma patients, this is a rule, must, that you should check for angle recession. Then careful periphery examination with indentation to look for retinal breaks or dialysis. Fundus autofluorescence is important to rule out associated RPE damage. OCT should be done. In OCT, we'll see traumatic macular holes are more eccentric or less circular than idiopathic macular holes. The horizontal diameter is more than the vertical diameter, and there is no correlation between visual acuity and the size of the traumatic macular hole. And invaluable for follow-up and monitoring, especially when you're observing it, because in management part for traumatic macular holes, it's a more conservative approach. So OCT is very good for monitoring it. So the conservative management, the rate of spontaneous closure is quite high in these cases. 50% of children and young, 28.6% rate of spontaneous closure in young adults. 37 to 44% within 2 months of injury. And a smaller basal diameter of the macular hole will also give good prognosis. Absence of intraretinal cyst on OCT is also an indicator for spontaneous closure. So there is a picture shown here of the fundus photo and the OCT of how it has closed spontaneously. So conservative management, like I just read out previously. Now the mechanism of spontaneous closure, the glial cell proliferation from the RPE to the basal surface of the hole. If there is an element of AP traction, occurrence of complete BVD will also assist in the hole closure. As commotio resolves, the edges of the hole may return closer to the RPE, resolving the central full thickness defect. Surgical management, the timing is key. Balance between waiting long enough for spontaneous closure but not so long that the likelihood of an anatomical success is reduced. So 1 to 3 months is the best timing to wait. The procedure, MIVS plus PVD induction, ILM peeling, ILM flap or an inverted flap with a gas tamponade, and use of adjuvants like autologous serum, TGF beta 2, platelet concentrate, and even amniotic membrane graft. Prognosis, successful closure rate is of 83% by meta-analysis. A trauma-induced photoreceptor and RPE damage limits the visual potential. These can appear several weeks after the injury. Ellipsoid zone attenuation on preoperative OCT and worse preoperative visual acuity are associated with poorer outcomes. So some studies by Dr. NEHA. And the take-home message. Traumatic macular hole is common in young men with closed more than open globe injuries. A careful examination should be done to look for RAPD, angle recession, and peripheral retinal breaks once ascertained that it's a closed globe injury. Eyes with extensive RPE damage on fluorescein fundus autofluorescence and choroidal rupture should avoid being operated upon. Cases in children, young adults with small basal diameter on OCT and absence of intraretinal cyst can be watched for spontaneous closure within 1 to 3 months. So conservative management is preferable, and surgical management will result in successful closure in up to 83% cases if selected wisely. Thank you. Thank you very much.